MRCP Part 1 aspirants and our honorable faculty. Today's class is about respiratory and it would be conducted by Dr. Nawaid Ahmed. He's a consultant in chest physician, NHS, and fellow of Royal College of Physicians. His area of interest are COPD, asthma, interventional pulmonology, and research. Over to you, sir. Now you can just proceed.
Thank you. So good afternoon, everyone. Well, it's afternoon here in UK, and good evening from wherever you're joining in other parts of the world. So today we are going to go through a few questions on the chest, medicine, respiratory medicine, particularly relevant to MRCP Part 1. So I'm told that you've not seen these slides before, so we will try and go through the questions one by one. And what I'll try and do is obviously help you how to navigate through these questions and get to the right answer. Just, to let you know that there will always be some questions in MRCP which are annoying, okay, and for which you may not know what is the right answer. So there are certain questions which are quite controversial, and even though you may think that this may be the right answer, it may not be, and that is a part of this exam, okay. But majority of the questions that come in the exams will come from the MCQs that you have done. So particularly the question bank that is there in the Farz Academy website, as well as some other question bank that you may be using. If you just go through the MCQs, then you should be able to crack this exam. The key thing is not to concentrate too much on the theoretical aspect of it, because theory is relevant to build a base knowledge. But if you have to, do this exam, then it is very important that you practice the MCQs. Now, obviously, some of you may not be accustomed with multiple choice questions, as during your MBBS or post MBBS, you may have just done more prose-like answers, but the MCQs are a different ballgame altogether, and the key thing here is to keep practicing the MCQs rather than actually relying too much on the theoretical aspect. So if there is a particular topic that you have to know in, for the exam, you do not have to go too deep into that topic, okay? You just have to know the basic things which will help you pass this exam. This is not a test of your expertise. It is not a test of how good a doctor you are. It is just an exam, and it has to be, seen in that way. So practice makes perfect. So if you keep practicing the questions, the MCQs, that is the best way of cracking this exam. Obviously, you may have to do a little bit of reading around the more popular question, just so that the knowledge base is strong. And but going too deep into the pathophysiology and the the pharmacokinetics of medications, etc., is absolutely not necessary. Okay, so I'll proceed with the first slide. This is a 33-year-old gentleman, as you can see from the question, fit and healthy. He was driving a car at high speed and got involved in a road traffic accident, and he sustained a closed fracture of his femur. He was taken to the emergency department, and he was found to be acutely short of breath. The patient seems confused when the treating physician speaks to him, and as he examines him, he notes petechial hemorrhages. So what do you think is the most likely diagnosis? So again, I think, there are reasons why, this road traffic accident has been mentioned here. Okay, there is a reason why you've got this closed fracture of the femur being mentioned here. So all these things are quite relevant in terms of what should be the the correct answer for this question. So if you have to think about it, then you can immediately say that most of the options given here are not true. So chest infection clearly is incorrect. This is not an asthma attack. There is no history of asthma given in the question. This is not a tension pneumothorax because, there is nothing, when you examine him, there is no mention of any reduced air entry on any one side. So the things that you really think about are PE and fat embolism. Now, if there was a history of, long haul flight, or if there was a history of post-operative shortness of breath which developed, say, within a couple of weeks of the operation, then I would think more about pulmonary embolism. But because this is a very acute presentation following the fracture of femur, the most obvious answer should be the fat embolism here. Okay. So the second question is about small cell lung cancer. And as I said, I think, in your for your exams, again, you don't need to know everything about small cell lung cancer. The topics that are quite popular are the paraneoplastic features of lung cancers. Okay, so you probably just need to know that. This is again another question, where you either know the answer or you don't know the answer. Okay, so this is a small cell lung cancer. Which one of these is a adverse prognostic feature? So if we go through the questions one by one, now finger clubbing is seen in all types of lung cancer. Okay, so that's not a prognostic feature at all. Small cell lung cancer presents with hyponatremia, not hypernatremia. Okay, so that's incorrect as well. Hypertrophic pulmonary osteoarthropathy again is not specific for small cell lung cancer. In fact, it can be seen in all types of aggressive lung cancers, so it is not true. Cavitation is seen in what is known as a squamous cell lung cancer and not in small cell lung cancer. So the correct answer here is increased alkaline phosphatase. So as I said, in MCQs, it is very important to try and rule out the options. If you're not very clear what the answer should be, so if you do not have any knowledge of what the answer should be, you simply look at the options and try and rule out each option one by one. If anyone wants to ask a question while I'm going through these things, please feel free to let the people in Farz Academy know, and they can then let me know if there is any question. They can unmute you. Okay. The third question, so this is a 20-year-old lady who's developed pleural effusions, ascites, and ankle swelling. Her blood pressure is normal, and the investigations are as below. So the serum ALT is normal, total bilirubin is normal, her serum albumin is quite low. As you can see, the normal range is 34 to 94. Her serum cholesterol is high. As you can see, the normal range is less than 5.2. So immediately you can think about a condition. So if she's developed these pleural effusions and she's got low albumin, then you're thinking about, transudative effusion. Okay, so low albumin with pleural effusions, and of course there is ascites, there is ankle swelling. So it's almost like anasarca. Okay. So if you've got a transudative effusion with low albumin, what is the next most appropriate investigation that you have to do? So as you can see, serum protein electrophoresis would be more, useful in multiple myeloma. This is not pregnancy. Anti-nuclear antibody, you would be looking at the autoimmune conditions. So from this, whatever is presented here, you can think of, quite obviously, most of you already thinking about nephrotic syndrome. Okay. So you're already thinking about nephrotic syndrome. So the correct answer should really be the urine protein estimation. Okay. So this is a case of nephrotic syndrome with high cholesterol and low serum albumin. And you can think about, so if you look at what we call transudative effusions, then transudative effusions really represent three types of failure. So if somebody comes in with bilateral pleural effusions and it is transudative with a fluid protein which is less than 25. Okay, so then it is a transudative effusion. And if it is a transudative effusion, you're thinking about heart failure, you're thinking about liver failure, and you're thinking about renal failure. Okay, so these are the three things you'll be thinking about. Now in this case, as you can see, there was generalized anasarca with a lot of protein loss in the urine. So the obvious answer would be checking for urine protein in this patient. So another question on small cell carcinoma of the lung. Which of the following non-metastatic manifestations is she most likely to develop? Okay. So again, you need to think about the paraneoplastic syndrome. So if you have to read about something for your exams with regards to lung cancer, then please look at all the paraneoplastic syndromes. And this is not only for small cell, but also for non-small cell lung cancer, and in particular squamous. Okay, so you will get a lot of questions on paraneoplastic manifestations of squamous cell lung cancer and small cell lung cancer. So as you can see here, they have mentioned, so myasthenia, hypertrophic pulmonary osteoarthropathy, Eaton-Lambert syndrome, erythema repens, and ectopic PTH related peptides. So this one you can immediately get rid of because this is something which is associated with squamous cell lung cancer, not with small cell lung cancer. Okay. Myasthenia gravis is an autoimmune condition, and it is not normally related to lung cancer, so it is related to the acetylcholine receptor antibodies. HPOA is a form of paraneoplastic manifestation, but again, it can be seen in all types of lung cancer, not specifically in small cell lung cancer. Erythema repens is not correct, so the correct answer you're left with is Eaton-Lambert syndrome. Okay, so this slide, you can take a screenshot of this slide because it will actually tell you about all the non-metastatic manifestations of small cell carcinoma. And rather than going through the books, if you just look at this slide, you will know what are the other paraneoplastic manifestations. So non-metastatic, or in other words, you can call it paraneoplastic manifestations. Okay. Now, one of the things that we talk about is dermatomyositis as well. So that is also quite, an important thing. So you need to just remember that. But you are more likely to get questions on Eaton-Lambert syndrome, hyponatremia, ectopic PTH-related peptide secretion rather than the rare complications as mentioned here. So please take a screenshot or just save this slide for future reference if you are reading about the manifestations of small cell lung cancer. So the next question is on connective tissue disease. So this is a lady with rheumatoid arthritis, and she has been on long-term therapy to control her disease. Now I'm guessing that this long-term therapy is probably just the DMARDs, okay, the disease-modifying anti-rheumatic drugs. And she presents with increased shortness of breath with a chest X-ray showing bilateral interstitial shadowing. Which of the following medications is the most likely cause of her symptoms? So again, this is quite a common question in MRCP. Drugs that cause interstitial lung disease. Okay, and the top one is methotrexate. So as you can see, that would be the correct answer here. But the other drugs could be, bleomycin, nitrofurantoin. Okay, so this sometimes you can have with metformin as well, and of course, methotrexate. So please remember these, because again, this is one of the quite a common question in MRCP. What are the drugs that can cause interstitial lung disease? So the bilateral interstitial shadowing means that there is increased reticular markings, and the interstitial shadowing indicating evidence of pulmonary fibrosis. So this is a question on COPD. A 74-year-old lady who wants to visit her friend in Philippines. Her FEV1 is 40%. Her last hospital admission was 5 months ago, and she is known to have significant kyphoscoliosis. Her oxygen saturation is 92% on air. She has a hypoxic challenge performed, and her PO2 is 7.7. What would be the correct advice? So for some of you who do not know what is a hypoxic challenge test, so hypoxic challenge test is basically allowing the patient to breathe allowing the patient to breathe an FiO2 of 15%. Okay, so normally in air your oxygen concentration is 21%, but when we are doing a hypoxic challenge test, the patients are breathing oxygen of 15%, and 15% meaning that tends to emulate the amount of oxygen present in the atmosphere at the maximum height of where the aeroplanes would fly, something about 4,000 feet. So that is how you do the hypoxic challenge test. So basically you're trying to find out if these patients will become hypoxemic when they move from an oxygen concentration of 21% to an oxygen concentration of 15% while in flight. Okay, so that is a hypoxic challenge test, and then there is certain criteria for that as well, which allows you to then specify what amount of oxygen will the patient need oxygen on the flight, or can the patient go on the flight without any oxygen requirement. Okay, so there is a criteria for that, and we will see that in the next slide. So hypoxic challenge test gives the patient a FiO2 15% for 15 minutes and measures the PO2. And these are the criteria here. Okay, so if the PaO2 is more than 7.4, okay, so they will do a capillary blood gas. If the PaO2 is more than 7.4, then no oxygen is required. If it is 6.6 to 7.4, it is borderline, then you should do a 6-minute walk test after this. Okay, and PaO2 less than 6.6, then in-flight oxygen is required. So please memorize this as well. So this is again, you will either know this or you won't know the answer to this question. Okay, so you have to just memorize the results of the hypoxic challenge test. And in this question, as you can see, the patient's PaO2 was 7.7, which is greater than 7.4, and hence in her case, no oxygen would be necessary. Okay. So this 57-year-old gentleman wants some advice on vaccination before commencing a healthcare job in the NHS. He's being treated for asthma with long-term steroids, and he regularly requires doses of prednisolone in excess of 30 milligram daily to control acute exacerbations. Which one of the following vaccinations would be contraindicated in this man? So this gentleman would be considered to be what we call immunosuppressed. If you're taking steroids, so prednisolone, so if you're taking prednisolone for 6 months at a dose of...
answer is a bacillus BCG.
Yes.
BCG we can give.
Correct. You're right. You're absolutely
Live
right.
vaccine.
Live vaccine. Very good. Yes. So this is the right answer. Okay. So because this patient is immunosuppressed, you need to avoid giving them any live vaccines. Okay. So how do you classify immunosuppression then if somebody is on steroids? So if they have been on prednisolone greater than 5 milligram per day, greater than or equal to 5 milligram per day for at least 6 months, okay, they can be classified as immunosuppressed. And this is also the requirement where you're trying to this is also the requirement for somebody needing osteoporotic protection. Okay, So if they have been on this dose of prednisolone for at least 6 months, then they are immunosuppressed and they will need osteoporosis. Now, it doesn't say, whether this patient is on steroid, but it does say that long-term steroids and regularly requires doses. So that means this person is immunosuppressed. So you would avoid giving them a live vaccine, which is BCG. So that's the correct answer.